So I'm very happy to be with you, my friends and my colleagues, and thanks for AIM Academy for this chance to see my colleagues and friends. So our lecture today about unusual techniques for immediate implant placement. So first of all, this is a picture for Dijle River. Dijle River is a river in our city, Baghdad. I'm from Iraq also, and I'm an oral surgeon and implantologist, by the way, and I live in Baghdad. And as you see, Dijle was splitting Baghdad in two parts, Al-Rasafa and Al-Karkh, and I live and work in this part, which is Al-Rasafa. And this is another picture for our city, Baghdad, and this is for the city center of Baghdad, which is Al-Tahrir Square. So our topics today, we'll talk about immediate implant placement and unusual techniques. We use it for immediate implant placement, which is socket shell preservation, drilling through roots technique, and ice cream cone technique, and also natural immediate implant for natural immediate implant provisional prosthesis. So first of all, immediate implant placement considered as widespread concept, which is mean that we extract the tooth and in the same time we put the implant, and which is meaning simultaneous implant placement with the extraction of the tooth. So this is widespread concept and very well documented osseointegration and success rate for this technique. But as you know, this is pictures for the extraction of the tooth and immediate implant placement and the final restoration. So the advantage of this immediate implant placement, as you know, we can use the extracted tooth as a guide because the socket lead you to the trajectory you should want to put the implant in it. Also, you get less time because you don't need to wait for the healing of the socket and formation of bone for 3 months, 4 months, and after that you put the implant. No, you just extract the tooth and after that put your implant. Also, it is better aesthetic because especially in the anterior teeth, because you know, with the extraction of the tooth, especially in the anterior teeth, the buccal plates of the anterior teeth was very thin, and sometimes it's about half millim or 1 millim or 2 millim. So this is very delicate and may during extraction make a trauma for this buccal plate. So so you may go to make a depression on the buccal plate and lead to an aesthetic appearance of the implant treatment or implant placement in this area. The disadvantage of the immediate implant placement, most of time or many times you can't get good bone for the engaging the implant. You have little bone or resorb bone in this area with immediate implant placement, especially if you have an chronic infection or acute infection. This is may lead to resorption of bone, so may lead to insufficiency of bone. That's meaning you can't engage your implant in the bone you want. So you first, immediate implant placement, is it enough to preserve the buccal plate? This is the question. Many times when you make extraction of or complete extraction of the tooth in the interior area, especially after few months, you can see some resorption on the buccal plate. So most of time you can't preserve the buccal plate, especially if you have delicate buccal plate, which meaning about half millimeter diameter or 1 millimeter diameter or 2 millimeter diameter. You can't get, or you can't rid of, or you can get rid of resorption or depression that make on the buccal plate. In this study, we see that 29% to 63% of the labial bone plates resorbed horizontally, and 11 to 22% vertically within 6 to 7 months. This is an immediate implant placement. This is happened in this study. So this is may lead to simultaneous tissue alteration, of course, because you get depression after resorption of this buccal plate, and this depression lead to depression of bone and soft tissue, of course, and sometimes this lead you to make augmentation of bone and soft tissue. So in order to deal with this resorption, we thinking about make a socket shell technique, which is mean retaining of root or part of root completely or partially to preserve the buccal bone. Cut the crown before extraction, and after that cutting the root and leave part of buccal plates or buccal roots on the buccal plate. This still should be still sticky or attached to the buccal bone, and after that putting the implant. This is to preserve the buccal plate. So the advantage of this technique was avoiding resorption of the buccal bone wall, also maintenance of the periodontal ligament, also contribution of our contribution to better aesthetic outcomes. What's the surgical procedure? First of all, this if you have a crown, or sometimes you don't have a crown, just badly carious tooth, you should to remove this crown. If you have screw or fiber post, you should remove it firstly, and after that make the cutting. The cutting start from the middle third, or also or sorry, start from the center of the root, and mesially and distally to splitting the root into buccal and palatal, and after that, after cutting, so your cutting will be sloped in order to cutting in order to remove the whole root of the tooth. So after cutting into buccal and palatal parts, you should remove any gutta percha or any remnants, and after that you should cutting also from the buccal part to retain just 3-4 millimeter, also 5 millimeter is fine, is good. So you should have to cutting the remaining or the socket shield into with the level of the bone, or also below the level of the bone. It's better to cut it with the level of the bone, or 1 millimeter below the level of the bone. And also the thickness of the shield should be not more should not less than 2, 3, 5 millimeter, 3 to 5 millimeter. Also, this technique have contraindication, which is presence of the periodontal disease. If you have mobility in this shield, you should have to remove it. If you have vertical root fracture or horizontal root fracture below the level of the bone, this meaning you should have to remove this socket shield and don't do this technique. And also if you have external or internal resorptions. This is the case. We see here that we remove the entire or the whole root. All the apex of the root should be removed. All the apex. Okay. You should cutting from the buccal in oblique line to retain the buccal shield, and after that you extract the tooth with whole apex and don't leave any part of the apex with the shield. After that, you can put your implant. It's better to leave a space between the implant and the buccal shield. It's better to leave it, and sometimes you can fill it with bone graft, synthetic, or even autogenous that's come from the drilling. It's good to fill the plan, and this is after 4 months. You can see here there is little or small parts of the buccal shield, and this should be removed or trimming. I make a trimming for it, and this is the final insertion. You can see here good gingival contour and good gingival healing, and no depression on the area. When you use immediate implant placement without and remove, especially as I said, especially when you you have half millimeter or 1 millimeter of buccal bone, after extraction of the whole tooth, you after and putting the implant, and you see on the follow up you can see a depression here, but with this technique you preserve the buccal plate and buccal area, and without any depression. This is a comparison between the immediate implant placement and conventional immediate implant placement and socket shield technique. This is take two groups. This is groups take the measurement from 3 months for the implant placement, 6 months, and follow up for 3 years. Here we use or they use the pink aesthetic score, which is a score for assessment of the single tooth implant by measuring the mesial healing of mesial papillae and distal papillae, gingival height, and gingival texture, and gingival color. So this, for this score, when they use it, they see that with the socket shield, it's better score than the conventional protocol. Also, for the marginal bone level, you can see marginal bone level in the evaluation that the socket shield give you better result. This is the case for the socket shield technique. So you can see here the buccal plate. طبعا, sorry, this is the CBCT. You can see here the buccal plate. The buccal plate about 1 millimeter or half millimeter. So if you extraction this tooth, make immediate placement as conventional, you should have conventional you should have depression on the buccal plate. But if you use this our technique, you can preserve this buccal plate and without any depression on this technique. This is the crown. You should remove the parts of the crown and cutting the root from the middle, removing the if you have screw, you should remove it firstly, and remove any remnants of cataberca or something like that. Sometimes you can get amalgam, and after that remove the part of the palatal part of the root with the whole apex. You should remove the whole apex. After that, starting the drilling. This is the drilling. Here, this is above the level of the bone, and should trimming to the level of the bone or below the level of the bone, and putting the implant. So here we can see some touch of the implant to the root. So it's better to leave a space between the implant and this socket shield. You should this is better. And if you want to fill it with the bone graft, it's better. In most cases, you have it's better to make immediate loading, or you can use second or use gingival healing to make a one-stage surgery. And this is after 3 months, and this is the final result. You can see here no depression. This is a final, and this is after 6 months. Okay, no depression on the buccal plate or buccal area. Let's see this video. This video show you the cutting and surgical part of the socket shield technique. This is the CBCT. Look to the buccal plate, about 1 millimeter. Cutting by turbine into 2 parts. This is the cutting into 2 parts, buccal and labial, and after that, removing the palatal part, removing it, and after that, putting the implant. Also, this is the palatal part for the second or the second central or central part, right one. This is the whole apex that's removed. And here the drilling. And this is the implant. Insertion of implant. And you see there is a space between the buccal shield and putting the healing abutment to be one stage surgery. And this is the x-ray, final x-ray. I'm sorry. Okay. There is a possible complication for the buccal and sorry, there is a possible complication may happen, like buccal and crystal bone loss. This is may happen. Maybe failure of osseointegration, and this is a complication may happen. Also, shield exposure, which is the most common complication that may happen. They may happen. Also, PD ligament and cementum formation on the implant surface. It may happen also. Also, it may have pocket information, inflammation, mucositis, and peri-implantitis. This is also the possible complication that may happen. So this is all that way we'll talk about the immediate implant placement by socket shield technique, which is used in the anterior implant placement. But in posterior implant placement or posterior immediate implant placement, you can't use this technique, but we can use another technique. There is challenging in the posterior immediate implant placement in the posterior area because we have a large extraction socket, especially in the multi-rooted teeth. Also, we can't get stability, so you have little stability in this area because especially in the upper part because the bone here in the posterior maxilla was type 4 bone. Also, there is anatomical limitation beyond the epic, like in the lower ID nerve or in the upper maxillary sinus. So the morphology also of the interradicular bone is different because the morphology be on the direction of the bone or the interseptal bone in the especially in the upper posterior teeth was mesiobuccally. This is the direction of the interseptal bone. So many implantologists they go to delay the placement on the posterior implant placement if they don't have bone, or they see difficulty in the putting the implant in the posterior part. Also, there is a difficulty in the multi-rooted teeth. It's better, as you know, it's better to put the implant on the center of the extraction socket. And this is, especially for the beginner, is difficult to put the drill because there is a slippage on the drill in this area after extraction. So there is a technique we'll talk about, which is called drilling through roots. So before extraction of the root, you make the drilling on the tooth, make the hole or hole for the implant placement, and after that, remove the roots and put your implant. And this is the technique, which meaning drilling through roots. In this technique, this is a study in 2017 for 22 patients with immediate implant placement on the first mandibular molar. For the control group, which is meaning the extraction of the mandibular molar, and after that putting the implant, we see just 3 implants placed in the central portion of the bone septums, while 8 are placed in the tilted axis. The test group, which is meaning the group of drilling through tooth, what I mean is just cutting the crown, if you have a crown, and make a drilling before extraction of the root, make the hole for the implant, and after that remove the root. For this test group, all of the implants they use it, all the implants was be in the central portion of the bone septums. For the ISQ, which is meaning implant stability quotient, which is a test for implant stability, we see the grades or the readings was similar. Also, we have indication for this technique, which is you should have absence of active infection. There's integrity of the roots, no ankylosis, no fused roots, no root resorption. Also, you should have and the the most important part was you should have sufficient bone to engage your implant like this. If you don't have sufficient bone to engage your implant, you can't use this technique. Absolutely. Okay. Also, there is a limitation of this technique because of hardness. The roots very hard, and this may lead to blind your drills or may fracture your drills. And this is difficult. You have difficulty with this. Also, there is altering to the normal healing because the remnants of the dental tissue that may retain on the whole of the implant placement, and this is may lead to altering the healing period. This is a case you see here. For this case, you should have to get CBCT for if you want to use this technique, because the conventional X-ray, you can't see the thickness of the bone or the bone between the or the interseptal bone thickness. You can't see it just by X-ray. Sorry, by CBCT. So for this technique, you should have to cut the pieces of the crown, and after that use the penetrate between the roots, and you have to get an X-ray during the drilling to check if you are in the right position or not. If you don't in the right position, just alter or change your direction and to be on the right one. After cutting and making the drilling for the implant placement, you can remove the pieces of the roots, and the removal of the root is very easier than remove it before drilling. For with this technique, you see that the extraction be easier, very easier, because all of the roots was separated and cutting, so you can remove it easily. And this is the implant placement. So in most cases like this, you should have to put a healing abutment, or sometimes if you can use posterior temporary crown, and if you have very good stability, but I prefer use a healing abutment to make one stage surgery, and this is after 4 months or 3 months. I'm sure you can see the healing of the gingiva is very good, and this is on the day of the insertion of the crown. This is the crown, okay, and you can see here the gingiva and the gingival height and the papilla, all of them was very good. Another case, also there is the CBCT. So for this area, I can engage my implant on this area. Okay. This is the X-ray during drilling. Okay. And this is the, sorry. This is the drilling, and as I said, you should have to check the X-ray during the drilling to check your direction if you have to change it, and after that remove the tooth and put your implant. And this is after 3 months, and this is the final crown. Another case also. So if you have bone, you can, if you have bone on the radicular bone between the roots, you can use this technique. If you don't have bone, don't use this technique. This is the drilling. You can see here. Check it by X-ray, and also we use here we make a sinus lift for this technique, because we don't have good bone, so you change our mind to make sinus lift. Okay. Another technique I will talk about, which is ice cream cone technique. So in these cases, sometimes you don't have a buccal plate on this side, as you see in this CBCT. Here we don't have a buccal plate. So in the conventional way, you should have to remove incision, make an incision and releasing a flap, and after that make bone graft and membrane, and wait for 3 months or 4 months, and after that put your implant. In this technique, we can use, if we want to use it, you don't have to remove a flap. Just with the immediate placement, just with the extraction of the teeth, put the graft and make your membrane as ice cream cone shape, and put the implant with the same time. So we use this technique, as I say, presence or partial or complete dehiscence of the buccal plate, shaping the membrane as like this, by like ice cream cone shape, and make a bone augmentation with it, and after that put your implant. So I will show you the video about ice cream cone technique. This video for the CBC, for this part of the lateral here, there is extracted lateral. First of all, you should make the drilling and prepare and shaping the collagen membrane to be as ice cream cone shape, like this. Okay, and put it on the buccal side of the implant or of the bone, sorry, putting the graft, and after that putting your implant. This is the graft. This is the graft, and this is the implant. And suturing. And this is the case after 5 months or 4 months, and this is the final for it. It's a good aesthetic area and good technique in these situations. Finally, I will talk about techniques. Not technique, but sometimes you have a patient with with central incisors, and he, this is for aesthetic, and he was a VIP or something like that. He don't have to be without teeth or without extracted teeth, and you think about immediate loading. So you have and you don't have a provisional crowns. Also, provisional crowns not get the color that you want. So if you have the tooth, the extracted, you can use the crown of this extracted tooth as a sorry, as a provisional crown. This is this technique provide as I said, acceptable gingival aesthetic, also better color for the crown, also maintenance of the interproximal contour with good palatal adaptation and better tooth shape. So you can see this case. This is the tooth that I want to extract. As I said, this is a chronic infection with this case, with repeated many times for RCT, and also obsectomy, and still there is still infection. So the decision was to extract it. Okay, so after extraction of this teeth, we cutting the crown and use the crown as sorry, as a provisional crown, like this. Okay, this is the crown, and this is the abutment. After removal of the root, we putting the implant, put the abutment, and prepare the extracted crown to be a provisional crown, like this one, and this is the final. Also, another technique, we have a vertical root fracture in this case. So I can use this crown as, okay, it's bad, bad aesthetic crown, but it's hair crown. It's better than use a provisional crown with an aesthetically color or an aesthetic shape or size. And this is after extraction, putting the implant here, and prepare the crown and prepare the abutment to receive the crown. You should have to put your crown away from the occlusion in order to prevent any premature contact that may lead to failure of implant. Okay. So finally, all these technique I talk about them. It's a promising technique, but it's not have long-term studies, not have long-term result, but it is promising. So we have lower power evidence and need further confirmation. So this technique, as I said, look like new techniques, need further confirmation and need more studies to make a power for it, because as I said, it's short term studies. Finally, I want to thank my colleagues and my friends and AIM Academy for this nice meeting, and I hope I see your question and answer on it. I'm very happy if I answer on my question. I'm very happy to be with you. I see the question, Mariam Hamid. For drilling through roots technique, can we make a surgical radiograph guide before procedure to make it easier for the beginners? You can use also, you can get for this technique, you can use a surgical guide for this technique. It's better, but I think it's long technique if I use surgical guide or and go to the lab and after that check it. I think it's better to use the radiographic X-ray during the drilling. It's better to get your direction. Ammar Luay, what's the fate of the labial part of the tooth? The fate, it's still on its attachment to the buccal plates, but I said there is a complication of exposure sometimes. This is the most common complication that happened, which is the exposure of the this is buccal shield, but I don't know if it is because another causes, maybe chronic infection, maybe there is a mobility. If you use this technique as the instructions that we talk about, I don't think you get this complication. But as I said, we need to more long-term study for this technique. But in my experience, most of cases you don't have any complication. Ahmed Majid, what the type of connection between the implant and the root? Osseointegration or cemento integration? Uh, in studies I read about it, case reports and studies, they say that there is osseointegration between the root and the the implant. But I don't know if there is this osseointegration happen because we leave a space between the implant and the root, or because it is attached to the implant. I don't know. But I read about osseointegration between the buccal plate, or sorry, the buccal shield and the implant. Okay. حذيفة معن الدباغ, please, how to make this sectional cutting? This is sectional cutting need special technique. Just you need be oblique cutting. You have to be a good expert to make this cutting and remove the whole apex. You should to remove the whole apex because the apex most of times source of infection. Mariam Hamid, why we have removed all the apical part? I said because we should remove all the apical part because most of time the apical part or the apex was a source of infection, and also to not interfere with the implant direction. You don't need to retain the whole of the all of the apical part. Just you have to retain a socket or shield on the buccal part. Just Osama, if the tooth is not endo-treated, do we need to extirpate the pulp? Also, for the partial extraction to preserve the bone, do we need to extirpate the pulp? Thanks. If you don't have endo treatment, no need for removal of the pulp, just cutting. But the idea of removing the getaberke or screw, because it may the remnant of the getaberke or screw or fiber post may interfere with the healing of future implant that we put it. Ghayath, how long is the lecture? It's 1 hour. Okay. Muhammad Taki, is there is a special tool to extract to leave the buccal plate of the root? You can use for me just I use a long shank turbine bear to cutting the root, and after that I use remaining root forceps, and I can use I sometimes use the sorry, special instrument which is periotome to remove the palatal part. Miriam, if not already have a problem, if the roots already have a problem, can we use bone graft instead and get the same success rate? Oh, of course, yes, of course, yes. But this is unusual technique or novel technique. As I said, it is don't have we don't have a long-term study for it, but it is a promising technique and easier than putting the bone graft and the membrane, and sometimes the bone graft, especially if it is synthetic bone, may don't get organization and may lead to failure. Dear doctor, we need just the buccal root or the buccal part of the root, and we remove the whole other part. Right? Yes, that's right. Just the buccal shield. Salam Ali Shali. If you have a periapical lesion, what must get loading? If you have a periapical lesion, and this is make big resorption in the bone, you can't do also you can't do immediate implant placement because you don't have a bone to engage the implant. You can't get it, so you should think about another technique. Qassam in the posterior mandatory to fill the root spaces with artificial bones. Better. Okay, thank you very much. Nice to meet you, and I hope to see you again in another another chances and another lectures. And thank you for AIM Academy for this nice meeting and nice lecture with my friends and colleagues. I'm very happy to be with you, and thank you very much. And thank you for everyone.